This time, and because of the time constraints, and we had got a shout from the organizer, so I'll just focus on showing you more cases rather than going in some text. ASD and BFO. ASD are the most common atrial septal communication. I'm speaking about the ostium secundum ASD. They are about 6 to 10% of congenital heart disease. BFO itself, as everybody was discussing, it can count up to like 25% of the adults. So we can close like 1/4 of the population will have ASD BFO closure device if we applied for the 1 or 2 bubbles rule. So as an echocardiographer, we have to assess the ASD in terms of shape and size, the rims for adequacy for percutaneous closure, the degree of shunting, and the secondary changes as well. Second change means the right-sided size and function and tricuspid regurgitation, if any. I'll just pass through this. This is just to show you the message here is that the BFO is not a direct defect, not like, for example, the ostium bramum ASD, which is a direct defect continuity. If you stand at the right side and then look, you will see the left side. But in the BFO, if you are on the right side, you will not see the left side because it's a flap and a potential space between primum and secundum. Looking at the septum, there are different types of defects. Hopefully, I will be able to show you all of them, examples. The superior and inferior vena cava sinus venosus types. We have the most common type, which is the ostium secundum ASD. We have the ostium primum ASD, which is near to the AB junction, and we have the coronary sinus, the unroofed coronary sinus defect. Again, looking at that, we know that this interatrial septum is not a line like in 2D, it's a wall. So if you are using transverse plane of imaging, like 0 degrees plane of imaging, it's better to scan the septum from up and down. So if you are using the 0 degrees, then you introduce a probe, then advance the probe down, so you will be able to scan the septum from up downwards or from down upwards. And you can also start by the bicaval view, which is almost at 90 degrees, and then at that time, if you can see the bicaval view, pushing down will not help you, it is sweeping from side to side. This is how to scan the septum in order to detect or exclude an ASD. Beta and foramen ovale, it was covered completely. As we said, it's like a potential space. If you are lucky, you will be able to see it from the left atrial side. This is a patent foramen ovale, open and closing, as you can see from the left atrial. But this is the only case I have seen like that. That's why I like it. Ostium secundum ASD is the most common type of atrial septal communication. As I said, what I'm doing here is using the 0 degrees plane of imaging here, and then introducing the probe from up downwards. So if you had a patient in the TUA list and you need to scan him to exclude or to detect an ASD, my advice is to start by 0 and then introduce a probe. And what I'm doing here, scanning from up downwards, advancing the probe down, so the defect is there, and then the defect will be closed again. That means I'm sweeping the septum from up and down. Scan the whole septum, that if there is any defect or more than one, you will be able to see them in 2D. The other way of doing it is actually I'm doing both. The bicaval view, which is now like I'm longitudinally cutting the septum and then scanning from side to side now, right and left sweep, and this is what I'm doing here. So that I can see the defect, and then completing the sweep. This is the SVC, IVC, the bicaval view. Again, the bicaval view is the most posterior part of the septum. So being intact doesn't mean there is an intact septum. There is a lot more of the septum to scan if you shifted the probe to the left side. After that, if you can see a defect, carry on your images. I will leave the suitability for closure for Dr. Hisham Naim because he will be speaking about that. So do not get caught by one defect and forget the others. For example, how many defects can you see here? There is, I don't know why it's stopping and playing again. Okay, anyway, this is ostium secundum ASD, and there is a BFO as well here. So do not get caught. All of us do this mistake. Sometimes even infective endocarditis, you see a mass on one of the valves, that's it, and then you forget another mass, another ghost hiding somewhere inside the heart. So this patient had BFO as well as ostium secundum ASD. 0 degrees, 4-chamber view is also very helpful. the standard views, the 45, and the longitudinal plane of imaging, which is the bicaval view. Okay, we have seen that. I will just go quickly. You have seen the Rattle maneuver to get the anatomical view for the interatrial septum. This is an example now of an ostium secundum ASD. In 2D, we could see the ASD as a line discontinuity. However, in 3D, you can see the wall, and this hole inside the wall, ostium secundum ASD. From one view, we can appreciate the rims, the shape. So we can see this is the SVC rim, IVC rim. Here is the coronary sinus, so the coronary sinus rim, the aorta, and the posterior rim. Obviously, this defect is very good for percutaneous closure. Other types of defects, fenestrated ASD, they are usually very thin septi, and they are multiple. Okay, you can see here many jets are going through from left to right. You can see the septum in 2D, a lot of defects. And this is a kind of septum that you don't like to image using 3D because it is very thin. A lot of defects will be there, dropout artifacts. But I can swear that this is one, and this is one, and this is one, but the others, I'm not sure. Because if you increase the gain, you will not see anything from the blood intensity. The blood will fill the cavity. And this from the other side, I can see this is the big one, another one, another one, another one, but otherwise, that may be just dropout artifacts. There is something called ostium secundum ASD. It is still an ostium secundum, but however, it is high ostium secundum ASD. And just modified bicaval view, you can see a defect here. This is not superior vena cava sinus venosus type. And we have to differentiate because the other one, the later one, is associated with anomalous pulmonary venous drainage. This is not. So you can see here the defect, real defect. It is not a BFO. And you can see the shunt. And by 3D, you can see this is the ostium secundum ASD, and this is superior vena cava opening. The previous one was right here. This one is high ostium secundum ASD, and from the left atrial aspect as well, I can see it. Ostium primum, it is the one near the AV junction due to defect in the septum primum itself. Our septum secundum didn't cover the ostium primum, that's why we have ostium primum and ASD. 0 degrees view, you can see the septum coming from the roof and defected here. In that cases, they are usually either complete AV canal defect, where you can see associated VSD, or partial AV canal defect. In that case, you will see cleft anterior mitral leaflet as well. And also one of the characteristic things here is both atrioventricular valves will be at the same level. There is no this apical displacement of the tricuspid annulus. So you can see the defect is just above the AV junction. Again, do not get caught by one defect because this patient had two defects. This patient had ostium primum defect and had a small ostium secundum defect as well here with some angulation. This is the same patient. And by 3D, this is the freeze frame from the right atrial aspect. This is the whole very, very big ostium primum ASD and a triangular ostium secundum ASD. From the left atrial aspect, again, very big ostium primum ASD and another ostium secundum ASD. Sinus venosus defect. This is one of the most common type I see personally is the superior vena cava type, although all of them are rare. Sometimes associated with anomalous pulmonary venous drainage, sometimes the right upper pulmonary vein connected normally, however, the drainage going to the right atrium, or sometimes the connection itself is abnormal and comes and connected to the SVC, like in this case. So he's very, very high. This is not high ostium secundum, which was here. This is really sinus venosus type. The shunt is there, and with some manipulation of the probe, you can see one of the pulmonary veins here draining. Right flow means coming towards the probe. So this flow is coming from the pulmonary vein, draining into the superior vena cava. This is the defect. And this view might be a bit confusing. This is superior vena cava opening. I'm looking from the superior vena cava itself, and I can see the opening of the right upper pulmonary vein. If you don't get it, forget it, no problem. Okay, this is my favorite because this is the only case I have seen degrowth coronary sinus in my life. This patient had a mitral stenosis and referred for me just for to check his feasibility for balloon mitral valvuloplasty. So I was just focusing on the commissures and the appendage, but the coronary sinus was dilated. The most common cause of dilatation of coronary sinus is the pulmonary hypertension, the right-sided hypertension, which is common in those patients. I said, okay, this wall, thin wall between the left atrium and the coronary sinus, that can be considered the roof. This is the barrier between the coronary sinus flow and the left atrium. Coronary sinus is a very low pressure tube because it just drains the coronary venous blood into the right atrium. With some manipulations, something started to happen here. There is de-roofing here. So this wall is absent, exposing the coronary sinus to the left atrial pressure, which was actually high in this case, particularly because of mitral stenosis. Even without mitral stenosis, still the left atrial pressure is higher than the coronary sinus. The bicaval view, as you remember, I told you this is not the whole septum, so in the bicaval view can be normal, but with some angulation. Now we can see the whole thing. This view is very telling because I can see here the left atrium, right atrium, superior vena cava, and this is the right atrial appendage. This small vessel is not the IVC. I will just go back one frame to show you the IVC. This is the IVC, quite big. As a rule, the IVC is at least as big as the SVC or even bigger. If you see a vessel on that side, which is smaller than the SVC, this is the coronary sinus. This is a common mistake. And this is the Eustachian valve, which is very big. Look at this view. This is another vessel, which is dilated again, the coronary sinus, with a Sebacean valve guarding the ostium of the coronary sinus. And this is the defect. Blood comes from the left atrium, blue, to the coronary sinus, and then there is acceleration of flow from the coronary sinus into the right atrium. Not because of stenosis, but because of the high flow. So this is de-roofing with left to right shunt indirectly from the left atrium to the coronary sinus and then back to the right side. With 3D, you can see here that this is like a 4-chamber view, left ventricle, right ventricle, interatrial septum, and this is the left atrial cavity. You can see this wall is absent. This is how the de-roofing looks like. The complete wall between the coronary sinus and the left atrial cavity is removed. So we have seen that in 2D, but just like a line discontinuity, but in 3D you can see the whole roof is not there. Okay, the last case. What is the defect type here? This is a patient that had mitral valve prolapse with regurgitation, so I was doing him for another reason. But then, with the short axis view, this septum was supposed to be attached here, actually. So there is a space here, and the septum is curved back into the left atrium. With some color, there is shunt, intermittent shunt, from the left atrium to the right atrium. The video is coming and going, okay? So there is intermittent shunt from the left side to the right side, and the septum is curving into the left atrium. So I thought, okay, just go for the other side and see where the septum is going. Septum is attached to the tip of the left atrial appendage, the comedine ridge, separating the left atrium into 2 chambers, something like cort triatrium, the left atrium. So we have superior portion of the left atrium containing the pulmonary veins, and we have an inferior portion with the left atrial appendage. So this communication is between the lower part of the left atrium and the right atrium. Look at the 3D here. This is the full volume, acquired and then offline analysis. I will start now probing to see the same view. This is the right atrium, aortic valve. This is the septum, and this is what I call it membrane. And then the defect will start with decreasing the gain. You can see that this membrane is not complete. It has a hole in the middle. So the 2 parts of the left atrium are communicating with each other. There is no complete separation. Otherwise, it will not be compatible with life, okay? So we have this membrane here separating both parts of the left atrium. We have this space between the lower part and the right atrium. Carry on. This is more clear now. Now I will probe from that side to need to see from here, like on fast view for this space. How does it look? What is this defect? And then I will rotate the image. I just need 30 seconds more, because this is very interesting. Just freeze, just a second. You would wait till the time finish first, okay. So I lost 10 seconds, okay. Okay, and then I will come closer. This is the defect. It's like a tunnel, opening and closing with the cardiac cycle. Yeah. Causing this intermittent shunt. It is not a fixed shunt. It is not I didn't find this suitable for any name. It is not a sinus venosus. It is not high ostium secundum. It is not ostium secundum. It's not a BFO. So I named it tunnel, interatrial tunnel, because it's like a tunnel between both. And we have actually published that. And it was reviewed thoroughly by a lot of reviewers, and they were against naming that like this. But at the end, I could fit it in. It was, I published that under the name of interatrial tunnel, a rare form of atrial septal defect. The guidelines is really recommending the use of 3D echocardiography to assess the shape and size and dimensions, because as you saw from the previous image, it is really dynamic. It is not fixed. So 2D can give you one frame here at the biggest, the other frame will be at the narrowest, but 3D you can freeze at the biggest frame and freeze and measure the dimensions and all the rims. So the second part of this presentation was about ASD closure, but I will leave that for Dr. Hisham. Thank you so much.